Welcome to our video on aphasia and neglect. Let's get started. Here is a general overview of the topics we'll be covering in this lecture. Let's begin by discussing aphasia. Aphasia is defined as an acquired abnormality of language, typically due to a focal brain lesion. It's important to note that this is a disorder of language and not necessarily just any communication problem, since there are many other disorders that impact communication. Okay, so you may be familiar with this picture from step 1. Before diving deeper into each of the aphasias, let's take a quick second to review some of the high-yield areas in the brain. Here is Broca's area, the speech production center. Notice that it's located in the frontal lobe. This is Wernicke's area, the speech comprehension center, and it's located in the temporal lobe. And the area connecting the two is called the arcuate fasciculus. Now let's review a brief picture regarding the blood supply to the different areas of the brain. Here, notice that the middle cerebral artery will predominantly supply Broca's as well as Wernicke's areas. Now, as you may be familiar with, Broca's aphasia is a type of aphasia wherein patients can't produce speech properly. It's a problem of language production with impaired repetition. However, their language comprehension will be intact. Usually, patients are also aware of the deficit, and when they try to speak, they become frustrated by it. Broca's aphasia is named this way because it involves Broca's area, which is the speech production center in the brain. This is located in the frontal lobe of a person's dominant hemisphere. Typically, it's involved with middle cerebral artery strokes. So you may see other associated symptoms, such as contralateral weakness of the face or arms. Now that we've covered Broca's aphasia, the other classic aphasia is Wernicke's aphasia. So let's discuss this now. This is a problem with speech or language comprehension with impaired repetition. Patients will typically be able to produce speech, but it will be nonsensical. You can help remember this with the phrase word salad. W is for word salad. Unlike in Broca's aphasia, patients here will usually be unaware of this deficit. Additionally, as the name suggests, Wernicke's aphasia involves Wernicke's area, which is in the temporal lobe of a person's dominant hemisphere. Typically, strokes here would involve the inferior division of the middle cerebral artery, so you may see signs like contralateral, homonymous superior quadrant anopia. Alright, so we've covered two of the high-yield types of aphasia in neurology. However, there are a few others. Conduction aphasia will have impaired repetition, but there will be preserved fluency and speech comprehension. Global aphasia is easier to remember since it is a global impairment. Or in other words, everything is impaired, namely language production, comprehension, and repetition. Anomic aphasia will have largely preserved repetition, fluency, and comprehension, but an impaired word-finding ability. In a way, they can't find the right words to say. It's a type of expressive aphasia. All right, let's review what we've covered so far. Damage to Broca's area will lead to Broca's aphasia. Damage to Wernicke's area will lead to Wernicke's aphasia. And damage to the arcuate fasciculus will lead to conduction aphasia. And damage to all three areas will lead to global aphasia, since everything is affected. Other aphasias include the transcortical aphasias, although they are also lower yield. You can remember, though, that they resemble Broca's and Wernicke's aphasias, though they have preserved repetition. So transcortical motor aphasia resembles Broca's aphasia, and transcortical sensory aphasia resembles Wernicke's aphasia, although Broca's and Wernicke's areas will be intact. The key point to remember here is preserved repetition. With regard to transcortical mixed aphasia, it will involve impaired comprehension of spoken and written language, but like other transcortical aphasias, it will also have preserved repetition. All right, let's try a question. A woman is undergoing evaluation in a neurologist's office. She is unable to follow instructions, repeat after the physician, or speak fluently without frequent word-finding difficulties. What type of aphasia does she likely have? All right, pause the video and take a moment to consider this question. If we were to tabulate this patient's language performance, she lacks fluency, repetition, and comprehension. This is consistent with the diagnosis of global aphasia. It's important to note that if this patient was able to repeat after the physician, the likely diagnosis would change from global aphasia to transcortical mixed aphasia. Hence, the key way to distinguish global aphasia from transcortical mixed aphasia is to assess the patient's ability to repeat after the physician. Okay, now let's review the transcortical aphasias. Damage surrounding Broca's area will lead to transcortical motor aphasia. Damage surrounding Wernicke's area will lead to transcortical sensory aphasia. And finally, damage to the surrounding watershed areas between the two will lead to transcortical mixed aphasia. In order to screen for aphasia during our neuroexam, we would test the patient's language ability. You might recognize that some of these tests are part of the standard mini mental status exam. Firstly, one of the most sensitive tests is to test the patient's naming ability. Typically, aphasic patients will not be able to name objects. Specifically, we can ask patients to name an object, such as a watch. Patients with aphasia can see a watch and mentally recognize that it is indeed a watch. However, they will not be able to say the word watch. Next, we can test for repetition. You can ask patients to repeat the phrase, no ifs, ands, or buts. An additional test we can perform is to test the patient's ability to read. We can show them a piece of paper that says, close your eyes. We would then ask the patient to read what's written on the paper and to do what it says. You can also ask patients to write a sentence. Aphasic patients are not able to write normally. However, this is not as practical to do in the real world. Most patients with aphasia typically regain most of their language abilities within the first month. Typically, patients can be referred to a speech-language therapist for treatment, since this period is when it's most likely to be effective. Other measures, such as pharmacologic therapy and transcranial electrical and magnetic stimulation, are currently being studied as potential treatments. Apraxia is the inability to carry out a learned motor task, despite having the capability or ability of doing so. For example, suppose you ask a patient to pretend they are hammering a nail or combing their hair. They will be able to comprehend the task they're given them and have the innate motor strength and coordination to do so. However, they simply will not be able to mimic these actions. You might notice that patients will be using their limbs as objects. For example, when combing their hair, patients might use their entire hand as a comb. Agnosia is the inability to recognize things despite having the sensory ability to do so. For example, patients may be able to describe specific features of a pen, but not recognize what the object is as a whole. For example, in visual agnosia, patients would not be able to recognize an object like a pen, even though they still have the ability to see the pen. Another type of agnosia that you may have heard of is called prosopagnosia, which is the inability to recognize faces. All right, now let's move on to talk about neglect, or to be precise, hemispatial neglect. Neglect is a neurological finding that occurs when there is lack of attention to one hemisphere. Hence, you can sometimes hear it being referred to as hemispatial neglect. Simply put, patients tend to be less aware of their surroundings on their left or right side. This typically is due to damage to the non-dominant hemisphere of the parietal lobe. One test you can perform is to ask a patient to draw a clock correctly. If they cannot draw one side of the clock, then that would be consistent with neglect. Another sensitive test you can perform is to check whether there is extinction of double simultaneous stimulation. To put simply, sensory stimuli are recognized one at a time, but not both at the same time. If both sides are stimulated, only one side, that is the non-neglected side, is felt. You can test this by lightly touching both sides of a patient, and you will find that they will only feel on the one side. As we stated in the previous slide, a person with hemispatial neglect will not be able to draw a clock properly. In fact, they will neglect one side of it. Here, this picture illustrates the fact that the patient neglected the left-hand side of the clock. Lastly, we'll discuss Gerstmann syndrome. As you may recall from step 1, Gerstmann syndrome is a constellation of problems that disrupts higher cortical function. It mainly involves agraphia, acalculia, finger agnosia, and right-left confusion. Agraphia refers to a person that cannot write. Acalculia refers to a person that cannot perform simple calculations. Finger agnosia means they can't recognize their fingers. And right-left confusion means that they confuse their right side as left, or vice versa. This classically is due to involvement of the inferior parietal lobe of the patient's dominant hemisphere. This is in contrast to hemispatial neglect, which involves the patient's non-dominant parietal lobe. Let's review the area that is affected by Gerstmann syndrome. Notice that it's the inferior parietal lobe. It's also very important to note that this will be on the patient's dominant hemisphere. All right, let's try another question. Which 3 specific components of speech should be assessed in order to confidently distinguish between Broca, Wernicke, and conduction aphasia? All right, pause the video and take a moment to consider this question. In order to confidently distinguish the 3 aphasia syndromes, it's important to assess the patient's fluency, repetition, and comprehension. If the patient has Broca aphasia, they'll be able to comprehend but not be able to repeat or speak fluently. If the patient has Wernicke aphasia, they'll be able to speak fluently but will not be able to repeat or comprehend a set of instructions. Finally, if the patient has conduction aphasia, they'll appear fluent and will be able to comprehend instructions but will not be able to repeat. Knowing these differences and manifestations of the 3 types of aphasias will help you confidently distinguish them on exams. Here you can see a review table including all of the key features of the topics we've discussed in this lecture. This should be a great table in helping you review the key elements of this lecture. All right, let's wrap up by doing another question. A 64-year-old accountant presents to her primary care provider with a chief complaint of brain fog. She says, "It's like I'm progressively forgetting how to do math." Past medical history is notable for hypertension, type 2 diabetes mellitus, and hyperlipidemia. The patient takes lisinopril, metformin, and atorvastatin. Vital signs are within normal limits. When the patient is asked to point to her right index finger, she points to her left ring finger. When the clinician looks through the review of systems chart that the patient was asked to fill out, he notices that it was left blank. The constellation of findings can most likely be attributed to a lesion in which of the following brain lobes? A. Left frontal lobe, B. Left parietal lobe, C. Left temporal lobe, D. Right frontal lobe, E. Right parietal lobe, or F. Right temporal lobe. All right, this patient is exhibiting the classic features of Gerstmann syndrome, which are acalculia, agraphia, finger agnosia, and the inability to discriminate left from right. Acalculia is suggested by her saying that she is progressively forgetting how to do math. Agraphia is suggested by the fact that she did not fill out a review of systems chart. Finally, finger agnosia and the inability to discriminate left from right are suggested by the fact that she was not able to point to her right index finger, instead pointing to her left ring finger. Given all of these features, Gerstmann syndrome is the most likely diagnosis. Recall from this slide earlier that Gerstmann syndrome occurs due to a problem in the inferior parietal lobe of the dominant hemisphere. Considering that in most people the dominant parietal lobe is the left parietal lobe, option B is the correct answer. And that concludes our lecture on aphasia and neglect.